So hi guys, welcome to the Parson Series, and today I'm going to take a very important topic, and that is your mechanical injuries. So nowadays, you have a lot of questions related to trauma. We have already done with the chemical injuries, and today we are going to do with the mechanical injuries. So let's get started. When I talk about the mechanical injuries of the globe, they can occur in a variety of ways and they are producing a number of sequelae. So you need to remember the name of ocular trauma classification group, which is giving you a uniform system for the classification, right? So you can divide it into two categories. We can have open globe injuries and closed globe injuries. When you talk about the open globe, that means it is the full thickness defects, and closed globe means without a full thickness defect. So it is easy to go. Now a number of injuries are included in each category. When I talk about the open globe, that also, closed globe, that also, which can occur alone also, or it can occur in various combinations. So we have got three zones which are described in these categories. Number one, we can talk about the anterior segment, which is going backwards. Then the injury is further graded with regard to the visual acuity as well as the afferent pupillary defect. Afferent pupillary defect is important here with respect to the optic nerve involvement. So this is an important flow chart for the classification of the ocular trauma. If you see, on one side it is your closed globe injuries, on one side we have open globe injuries. Now when it is a closed globe injury, can you see? It can be a foreign body, it can be a contusion, or it can be a lamellar laceration. But when I talk about the open globe injuries, it could be a laceration or it can be through and through rupture. Now lacerations can be penetrating injury, perforating injury, or intraocular foreign body. And I hope you remember what is the difference between penetrating trauma and the perforating trauma. Penetrating trauma means there is only one entry wound. Penetrating trauma matlab through and through, right? Entry and exit wound, both are there. Alright, so if I talk about the open globe injuries, first of all, they can occur due to blunt trauma, and anything related to blunt trauma is important when they are known as the ruptures of the globe, right? Then they can be caused by the sharp objects. So I'll make it green. When it is occurring by the sharp objects, then it is called as a laceration. Laceration will be your full thickness. Now when sharp objects are causing the trauma, as I told you just now, it can be a penetrating trauma or it can be a perforating trauma. Perforation means both entry and exit wound present, right? Now the closed globe injuries, they can follow the blunt trauma, and they are also called as contusion or the concussion injuries. So whenever you are being talked about the contusions or the concussions, they are same as that of the blunt trauma. Then we have got your superficial foreign bodies. They can easily be found on the cornea and conjunctiva. So foreign bodies are really common in the ophthalmopedies. Whenever we are having a serious and a busy OPD, we have a lot of foreign bodies on the cornea and conjunctiva. Right. Then we talk about the lamellar laceration. Lamellar means what? Lamellar means a layer. So we have got the laceration, that is your partial thickness. If it is in a particular layer, if it is only a partial thickness, then this is your lamellar laceration. Now let's talk about the superficial foreign bodies. Superficial foreign bodies. Now these foreign bodies can be the small particles of dust, iron, steel. They can go in the conjunctiva or the cornea, and whenever they are going in the conjunctiva or the cornea, they can cause sudden discomfort, they can cause blinking. Now what happens? The palpebral conjunctiva is a very good place, I can say it's a very good place for the foreign bodies. So these foreign bodies are going in the palpebral conjunctiva, they are dragged across the cornea, and there it creates a problem because the moment it is going into the cornea, we have got different layers of the cornea, so it is causing the epithelial abrasion. It can go deep inside, and then it can invite a number of the infections which can cause the bacterial corneal ulcers. Then it can be washed by the tears, then it is going into the nasal duct, then it can be lodged at the middle of the upper tarsal sulcus where it may irritate the cornea, or sometimes it can go into the bulbar conjunctiva. But most of the time bulbar conjunctiva is not a problem because bulbar conjunctiva is easily visible, plus we have a lot of tears, it can easily wash away from that place. But if it is going in the palpebral conjunctiva, then obviously it is densely adherent. They are they are more stubborn foreign bodies are there, and it's more difficult to remove from there. Fairly large foreign bodies. Now sometimes we have got very, very large foreign bodies, like grain of a corn may be retained in the upper fornix, and lot of irritation and discharge could be there. You may not find it practical, but this happens, and this has occurred with our OPD so many times. This may be overlooked unless the upper lid is double everted. So at this time you have to double evert the eyelid, and only then you can see. It can be embedded in a mass of granulation tissue, which may stimulate coxcomb type of tuberculosis. So this is a typical type of tuberculosis you can see here. The wing cases of the insects and husk of the seeds may adhere to the cornea by their concave surfaces. Then we have got another kind of foreign bodies, like we have got the particles of the iron and steel. They can also go into the cornea, and this is really important. Foreign body iron, it has been recently asked in NEET 2021 also. They can penetrate. So they are going into the epithelium or the substantia propria. What is substantia propria actually? This is adenoid layer plus the fibrous layer. When these layers are joined together, they are called as the substantia propria, which is commonly having the degenerative changes. Then if you have still larger particles of the steel or stone or glass, they may also cause the perforation of the globe. When situated in the cornea, they will cause pain, they will cause irritation. Pupil is constricted in cases of foreign body. This is again important. And if you are not removing them at the right time, they can expose the cornea to the dangers of the infections also. The ulcer that is formed, that can be with or without hypopyon. So as I told you, whenever you have something that can erode the epithelium, you are inviting the corneal ulcers. Okay. So see, this is a very, very common one. See, a commonly get pictured. This is a foreign body over the cornea, metallic foreign body, right? It is not easy to discover a foreign body on the cornea, a very golden line. It's not easy. So sometimes you have a foreign body on the cornea and it's not visible by the naked eye. You keep on having photophobia, you keep on having irritation, pain, and you're not able to find out. Actually, you're not able to realize that there is a foreign body, and therefore you are not going to the ophthalmologist. You are just going to a family physician, and he's just giving you tobramycin every now and then. So a great problem. The use of a fluorescein. So what you are going to do, ophthalmologist, we just stain it with the fluorescein, and very easily and beautifully we can get this foreign body there. That can also reveal the position of the foreign body. In case of the doubt, you can do the anesthesia. You can see the cornea thoroughly under the oblique illumination with a slit lamp. You can see the nature of the foreign body, the position of the foreign body. So slit lamp and fluorescein staining, I think are two important things that will help you in finding this foreign body, right? So I am going to mark fluorescein, I am going to mark the slit lamp here, two things here, right? Now treatment. So you know that how much problematic they are, so you have to remove them as soon as possible. If they are lying loose, then what you have to do? See, if they are lying loose in the lower fornix, so in the lower fornix, they can easily be removed with a swab. You can just evert the lower eyelid and you can remove it. If not found in this position, then what you are going to do? Evert this upper eyelid and even double everted with a Desmeyer's retractor. So you can do the double eversion with the help of a Desmeyer's retractor. The particle will generally be found where in the sulcus subtarsalis, and again you can remove it. In case of difficulty, you can also do the anesthetization. So here double eversion with a Desmeyer's retractor, sulcus subtarsalis, and as soon as possible, I think are the three important things that you need to remember. If the foreign body is embedded in the bulbar conjunctiva, it should be removed with a foreign body spud or fine forceps you can take, or you can use the disposable sterile needle. Foreign body from the cornea are removed under magnification using the slit lamp or operating microscope. Anesthesia is always used in these cases. Surgeon will hold the lids apart, something like this, with the first and second fingers. right, and pressing slightly backward so that you can easily visualize the foreign body. An attempt may be made to remove the foreign body by dislodging it with a sterilized spud. If you are not able to do it with the help of this, then what you else you can use? After the spud, we can also use a disposable hypodermic needle that you can use, but you should not scrape the epithelium. Now again, an important thing, should not scrape the epithelium, because if you are scraping the epithelium, if you are causing the epithelial erosion, again you are inviting the corneal ulcer, right? Stone, steel. What are the different things? Stone, steel, iron particles leave behind a little ring of brown stain, which should be scraped off if possible without too much trauma. Now, usually whenever you are getting the foreign bodies like the glass or the iron or the steel, you are also getting the stain of the rust. So, basically we should try to scrape it off, and if it is not possible absolutely, then you can leave it. In all cases, you have to use an antibiotic ointment, you have to use a bandage. Then ulceration, if it is occurring, obviously you have to treat it on the lines of corneal ulcer. Special attention should be paid to the particles of the stone. Stone has a greater tendency for infective ulceration. Why? Because metallic particles are hot, and hot will become sterile, while stone is not hot, and that will cause more ulceration. And that is the reason that they can ask you this question, which has greater tendency towards the infection. So it is actually the stone. Occasionally the sharp steel and other particles, they penetrate deep inside the cornea. Efforts made to remove them may push them even deeper. Sometimes steel particles and all, they are lying and you are trying to remove them and they are going more deep inside, and that is the reason why we say that if you are not an ophthalmologist, please don't try to remove the foreign body, don't try to touch the eye, just refer the patient. Okay, when such an accident is feared, special precautions must be adopted. If a particle is magnetizable, then you can do the magnetic removal, that could be there, but it is usually necessary to incise the cornea overlying the foreign body. However, this method may fail, particularly if the particle is small. So you will not be able to scrape off the cornea overlying it. If the foreign body escapes into the anterior chamber, once it has gone into the anterior chamber, then we have number of methods we can remove it. Now, what are the prophylactic measures? Before, going to the therapeutic measures, prevention is always better than cure. So what are the prophylactic measures? They are extremely common in the industrial workers, working with the grinding tools, lathe work, hammering on a chisel. So there is a lot of danger. So great effort should be taken in these people, right? So in addition to the banning tools with overhanging edges, fitting of guards should be there. We can also prevent these accidents with the use of goggles. So that is a boon, I think. Please use goggles. Every attempt should be made to protect the eye by educative notices and lectures as well as the comfortable goggles. तो शिक्षा तो देनी ही देनी है, उसके साथ साथ goggles भी दो, क्योंकि both of them is important. Right knowledge and the right tools will be coming to the rescue. Now the closed globe concussion or the contusion injury. If you look at the mode of injury during the blunt trauma, it can be a coup. Coup means direct trauma like corneal abrasion, or it can be a counter coup. Counter coup may distant damage due to the transmitted pressures. Numerous lesions may result. Indeed, every part of the eye may be so injured by a contusion. So it could be a direct hit also, and it could be an indirect. So if I am hit here, so this will be a direct and this will be a counter coup injury. Moreover, in some cases the changes are delayed or progressive, so that in all cases a guarded prognosis should be given and patient kept under review for months to years. Now, if you look at the mechanism of the blunt trauma, as a general rule, what you are going to do, either the anterior segment of the eye in front of the iris, lens, diaphragm, or the posterior half is affected. So whenever I am talking about the blunt trauma, anterior segment is also affected, posterior segment is also affected. I hope you remember, anterior segment means the structures anterior to the lens, including the lens. Posterior segment means structures posterior to the lens. So when a force impinges upon the cornea, this tissue is causing the thrust inwards. So from the cornea, It's going to the iris, it's going to the lens, aqueous humor, then it's going to the back of the eye, and from there it is going to the retina, choroid, angle of anterior chamber. So you have lot of complications. We have glaucoma also, cataract also, hemorrhages, vitreous hemorrhages, retinal detachment. So blunt trauma is mind-blowing. You know, whenever we are getting a trauma by a fist injury, punch injury, balls, it can be a tennis ball, it can be a cricket ball, it can be a football. We can have the changes in whole of the eye, right? So they have shown you what are the effects of this concussion injury. It's going from anterior side and it can go towards the posterior side also, right? So see, there is a total list, so many ophthalmic effects of the concussion or the contusion injury. Start with the orbit. Orbit may most important is the blowout fracture. Otherwise, we can have hematomas also. We can have keratico-cavernous fistula. In the keratico-cavernous fistula, you have PCB. P for pulsatile proptosis. This is very, very important. Then we have chemosis. Chemosis is the edema of the conjunctiva, and B for brew, which is actually the noise in the head. Then in the eyelids, we can have hematomas, we can have avulsions of the lower eyelids. Subconjunctival hemorrhage is important. Then anterior uvea. Means in the iris, we can have hyphema, we can have iridodialysis, cyclodialysis, angle recession. Hyphema, what is hyphema? This is your blood in the anterior chamber. Iridodialysis is detachment of the iris from the root. Similarly, cyclodialysis is the detachment of the ciliary body from its root. Angle recession. Recession में the ciliary muscle के two fibers हैं. We have circular fibers, we have longitudinal fibers. Both are separated. That is angle recession. Then this is very, very important. Rosette cataract. So there are so many things that can occur to the blunt trauma. Subluxation भी हो सकता है. Then retinal dialysis भी हो सकती है. We have iridodialysis also. We have choroidal dialysis also. We have retinal dialysis also. We have cyclodialysis also. तो पूरा ring है. Optic nerve avulsion. Macular hole or macular edema. So this macular edema is also called as the Berlin's edema, and Berlin's edema give you the cherry red spot. So this is also coming under the DD of the cherry red spot, right? So I think whole of this flow chart is really, really important. यहाँ पर हम important लिख देते हैं, ठीक है? This is important. Then coming to the cornea. Cornea में we can have abrasion, deep opacities, rupture. Abrasion is just a superficial loss of epithelium, right? This can occur due to simple dust particles or foreign bodies. You have distortion of the corneal reflex, and as I always say, cornea means fluorescein. You can easily discover it with the fluorescein. You can put the antibiotic eye drops. So if it is just a small abrasion, it can heal spontaneously. You can use antibiotic ointment, a little cycloplegic for the pain relief, and you can do bandaging. But if you have recurrent erosions, so in cases of the recurrent erosions, which can even occur spontaneously, particularly very, very common with the fingernail trauma, babies. So the abrasions, however, proceed, usually heals quickly, but is followed some days, weeks, or even months. Afterwards, we have pain, we have lacrimation, especially when we get up in the morning. So at first, they are not having that much, but afterwards, we are having lot of pain and lacrimation. If the cornea is stained with the fluorescein, you will see that there is actually a abrasion, usually at the original side, but sometimes elsewhere also you can get. So this attack rapidly passes off with the appropriate treatment, but it is reoccurring repeatedly, especially when waking up in the morning. There is no doubt that in these cases, epithelium is abnormally. So why? What is the problem? Why we are having recurrent erosions? Because epithelium is loosely attached to the Bowman's membrane. So it is easily torn off in the morning. So this is again an important thing. Early attacks should be treated in the same manner. But if we are having the repeated attacks, if I am having the repeated attacks, then debridement is there. What we do in cases of debridement, you remove this loose epithelium, and then you can do the padding for 48 hours. Or another thing we can use is the band-aids of contact lenses. So that could also be there. But if you are going with the deep opacity, deeper opacity is occurring due to the contusions. So we have delicate gray stria, they may be interlacing in the different directions. We have the edema of the corneal stroma, we have wrinkling of the Descemet's membrane, we can have ruptures in the Descemet's membrane that can lead to edema of the stroma also, right? So see, we can see the vertical Descemet's membrane tears. So this is again important. Here you are getting the vertical stria, while in congenital glaucoma, H for half and H for horizontal. There you were getting the horizontal striations. Then coming to the blood staining of the cornea, again it can result due to the contusion which has caused a hyphema. Hyphema was causing the raised intraocular pressure, it was causing the endothelial damage. So what is happening in the blood staining? Entire cornea is getting stained and the color will vary according to the duration. So it is just similar to the bruise. This color will vary according to the duration of the condition. Like it could be reddish brown, greenish, or it can also simulate the dislocation of the clear lens. Then we have slowly and gradually cornea clearing, and you know, this process usually takes a longer time. So you don't have to make fuss or panic. It taking 2 years or more. Microscopically, what you are going to see here is the myriads of minute, highly refractile rods which are packed in the lamellae of the stroma, which are actually the derivatives of hemoglobin, because blood staining is a blood, yeah, na? So this may contain iron, may not contain iron, and this will be removed slowly and gradually by the phagocytic action. In the absence of other causes of defective vision, sight may eventually be restored, but is usually permanently impaired. So, you know, usually we have lot of visual impairment whenever cornea is involved, but sometimes person may be lucky enough that we get the vision. If I talk about the sclera, usually we can have the rupture of the globes. Rupture of the sclera is common in cases of the open globe injury, and this is occurring whenever we have sudden trauma, we have violent trauma, or you know, you are falling on some object like a knob or a key in a door, and this force is usually coming from which direction? Infratemporal direction, because you know, eyeball is having least protection in that direction. So the globe is actually pushed against this superior oblique pulley. So inferiorly we do not have that much of protection, and that is the reason that maximum trauma we are having in the infratemporal direction. So that is your at its weakest part, which is near the canal of Schlemm. Conjunctiva is intact. We can have iridodialysis, we can have subconjunctival hemorrhage, we can have deeper anterior chambers, we can have subretinal hemorrhage or the suprachoroidal hemorrhage. So this we have already discussed in the flow chart. If you go with the treatment, we have to carefully examine it. You have to use the anesthesia, you have to retract the eyelids, you have to see what is the extent, iris is prolapsed or not, right? And then you can do the suturing by the mattress suture 80, or you can use the propylene sutures. So if this rupture is actually extending posterior to the ciliary body, if it's going posterior to the ciliary body, then you have to be very cautious, because you know, there could be chances of retinal detachment. So you have to give the cryotherapy also in that case. If the rupture is extending posteriorly, you can also have vitreous hemorrhage, retinal detachment, we can have a late retinal detachment, then we can do the vitreoretinal surgery. Now, what is the best time of doing vitreoretinal surgery? 10 to 14 days after the injury. So, this is again an important question. Then you have to give the antibiotics, corticosteroids, right? Why we are giving corticosteroids? Because we want to prevent the sympathetic ophthalmitis, right? So they are asking the question and they are giving you the answer also. Then if there is no light perception, a lot of defect is there, then do the excision, do the enucleation. You do not have the choice then. Right. Now coming to the iris and ciliary body. So iris and ciliary body may, because of the trauma, we can have iridocyclitis, and iridocyclitis ke wajah se you will have meiosis. So this meiosis is actually temporary, but long term mein you will have the dilatation, that is mydriasis, larger irregular pupil. Then you can have detachment of the iris from its root. We can have iridodialysis. We can have detachment of ciliary body from its root. We can have cyclodialysis. And you know, iridodialysis actually leads to the D-shaped pupil. So what is iridodialysis? See, if you make this is your iris here, and this is your central pupil. So we'll make it black in color. This is your central one. So if I am having the detachment of the iris from its root, so it will become like this. We have a biconvex area. So we have a biconvex area here. This is iridodialysis, and this is going to, you know, compress this pupil now. So when it is going to compress, now it will become something like this. This is the iris, this is the detachment, and this becomes the D-shaped pupil. So this is a biconvex area of the iridodialysis, and this is your D-shaped pupil, something like this. This is iridodialysis, and this is the D-shaped pupil. I hope this is very, very clear now. Then what else? With ophthalmoscopic mirror, a red reflex can be obtained. Then due to this, because you are having two pupils now, because one is this pupil and one is this pupil now, we are having two pupils. So because of this, we can also have the uniocular diplopia, right? Then in the extensive iridodialysis, it you know, जो detached iris है, that can be entirely antiflexed. So it is completely rotated. That is called as the antiflexion of the iris. So in that cases, you have to reattach the iris, okay? And you know, sometimes we have serious consequences. So this is your case of iridodialysis. You can see here, this is the detachment and this is your biconvex area here, right? Then we can have aniridia. Sometimes, you know, iris is completely torn away from its ciliary detachment. We can have retroflexion, जैसे कि it was rotated anteriorly, it can be rotated posteriorly also. So we can have a total inversion, we can have retroflexion also. Then sometimes, you know, it is inverted in such a manner that it looks like a coloboma, but actually it is not a coloboma. So that is called as colobomata, right? Then angle recession we have already talked, where there is a separation between the circular and longitudinal muscle fibers of the ciliary body. This is your angle recession, which is seen on the gonioscopy. Histologically, the longitudinal tears in the face of the ciliary body, which is split the circular from the radial fibers. So I told you the both type of fibers are separated from each other. Then we can have hyphema. We can, this traumatic hyphema, what you are going to do, you have to hospitalize the patient, and hyphema occupies more than half of the anterior chamber. Then you have to observe for 72 to 96 hours because of the danger of secondary hemorrhage. Again, important thing they can ask you. This, the eye is patched, patient made to rest. And a very important thing is atropine and steroids have no role in this management. So you have to give the bed rest, observe the patient, and use the glaucoma therapy if the IOP is raised. Again, aspirin is avoided, and treatment with sodium acetate may be used to prevent the rebleeding. So atropine has no use, steroids has no use. Give the anti-glaucoma drugs, and what should be avoided is the aspirin. These are again the important things, 1, 2, 3, and this is 4. If pain is unrelieved or there is a threat of blood staining, you can also do the evacuation of the central clot with the help of a two-way irrigation cannula. All right. Then you can sometimes do the glaucoma surgery also if it is not able to control with the help of the drugs. This is your traumatic hyphema. Can you see here? This is the blood in the anterior chamber, traumatic hyphema. So here what you are going to do, you have to give the anti-inflammatory medications. When the eye has settled, iridodialysis is gross. Symptoms such as diplopia, you can also suture it with the help of proline sutures. In the lens, we are getting the cataract, that is called as a Rosette cataract. Then an important thing is a Vossius ring. Vossius ring was asked in the NEET 2021 also. There, what is happening if there is a blunt trauma, something like this, and this is your lens. So this, you know, iris will go and make an imprint over the lens. So when you see it from front, the pupillary margin of the iris will make an imprint on the anterior surface of the lens. This ring is actually called as a osseous ring. So it's a constricted pupil which is imprinting over the lens. This is your osseous ring, right? Okay, then we have a cataract. Cataract mein, all you need to know is that the type of cataract is a Rosette cataract, nothing much, okay. It is a star-shaped cataract, that also you know, and that is known as Rosette cataract, that much, right. So this is the picture of the Rosette cataract. Then we can have the subluxation of the lens. We can also have the osseous ring. So three important things: the Rosette cataract, the osseous ring, and the subluxation of the lens. See, here you can see the lens is dislocated anteriorly, right? So this is also there. Then now what is happening due to the subluxation? Why? We have the slackening of the ciliary zonule. So they are bending anteriorly. We can also have increased curvature, and that is why we can have lenticular myopia. So refractive status may, you can remember this. This is your posteriorly dislocated lens. So both the pictures you can compare. Treatment may, the lens you can extract with the help of a cryoprobe. You can use the vectors, and you can also do the anterior vitrectomy if there is subluxation. In the vitreous, there can be detachment of the vitreous, and there can be hemorrhage of the vitreous. So two things you need to remember. Then choroid may, again detachment as well as hemorrhage. So vitreous and choroid may dono same. Then rupture of the choroids could be there. We can have the choroidodialysis, we can have choroidal detachment. This will lead to the hypotony, and if it is ruptured near the macula, then there will be loss of the central vision also. Only that much. Okay? Then sometimes a late complication can be neovascularization. So we will make it very short and concise, easy to remember things. This is your choroidal rupture, and as I always say, keep on remembering the pictures, they are important. So that can also lead to choroidal or suprachoroidal hemorrhage. Finally, we come to the retina. In the retina, we can have edema, we can have degenerative changes, and this is commotio-retinitis or Berlin's edema, has been asked so many times. Very, very commonly found in cases of the blunt trauma. You are going to get a milky white cloudiness, right? So you know, whenever there is a strong blow which is going up to the retina, we can have this commotio-retinitis. Then if it is more severe, then we can even have the intraretinal hemorrhages, right? Then we can have macular degeneration. So macula mein macular hole and macular edema, two things are important. We can have macular holes, they are there. Then we can have the retinal holes. Retinal hole can lead to retinal detachment. Retinal detachment, which type? Rhigmatogenous, which is related to retinal hole. So you will have actually the RRD. Then lately we can also have the proliferative choroidoretinopathies. Optic nerve may, you can have avulsion of the optic nerve, that's it. Intraocular pressure may, we can have hypotony also, and we can have glaucoma also. Hypotony due to the ciliary body detachment, and glaucoma due to the traumatic hyphema. So two important words, and that's it. Traumatic hyphema, right? That much is okay. Then we come to the open glow penetrating injuries. Open glow penetrating injuries means which are caused by the sharp instruments or the foreign bodies, and here the patient should be immediately have a eye shield applied. You have to observe under the general anesthesia. You have to do the evaluation for the repair, because you know, we have a lot of things that can happen in this patient. We can have the iridocyclitis, we have a risk of infection as well as the risk of sympathetic ophthalmitis. Right? Now, if we have wounds of the conjunctiva, we can do the suturing. Suturing you can do with the absorbable sutures. If we have the wounds on cornea and the sclera, again, we can do the suturing there, right? So, closure of the wound can be there. So, these are your corneal as well as the conjunctival suturing in cases of lacerations and perforations. So I hope you people have understood the effects of the mechanical injuries, and you have also seen that will be its effect on the different organs. What are the important words that you need to remember so that you are able to solve all the questions very crisp and very concise, and all the previous year questions that have been asked over these topics. Thank you and happy ophthalmology.